Welcome to the webinar, Capacity Building of Advanced Practice Nurses in Managing Patients with Diabetes. This course is published by the University of Alabama at Birmingham School of Nursing, a Pan-American Health Organization and World Health Organization collaborating center. I'm Dr. Nancy Rudner, an associate professor at the School of Nursing. With us today are two experts in diabetes care, Dr. Bella Patel, an instructor in the School of Nursing, and Dr. Michelle Talley, an associate professor and assistant dean in the School of Nursing. Drs. Patel and Talley are also advanced practice nurses working with patients with diabetes in the Nurse Managed Care Center. Diabetes and the role of advanced practice nurses. At the conclusion of this program, participants should be able to identify the role of advanced practice nurses in diabetes prevention and care in the United States. Participants will be able to identify 3 modifiable and 1 non-modifiable lifestyle factors that contribute to diabetes and blood sugar control complications. Additionally, participants will be able to articulate strategies for prevention, early detection, and management of diabetes, and describe key concepts in insulin management and safety. Diabetes is a growing concern in the Americas. The prevalence of diabetes has increased threefold since 1980 and is projected to affect more than 100 million people in the Americas in the next 2 decades. With that, the cost of health care due to diabetes is expected to approach $500 billion. Nonetheless, many people who have diabetes do not know they have it. 30 to 40% of those with diabetes in the Americas are undiagnosed, and it is the 4th cause of death in the Americas. The good news is that diabetes can be controlled by healthy eating, physical activity, and medication. But the lifestyle factors are a challenge. Over 8% of men and women have elevated blood sugar or blood glucose. Obesity and being overweight is very prevalent, over 60% of adults. 1/3 of men have insufficient physical activity, and 45% of women do not have sufficient physical activity. Tobacco use remains a challenge. Nurses work with diabetes in many ways, in primary care, acute care, and community care. In the United States, the advanced practice nurse is able to assess patients, diagnose diabetes, treat, which includes prescribing, as well as educate patients and provide support. The enabling policies and regulations for the advanced practice role include licensure, which determines the requirements to be an advanced practice nurse and the scope of practice. Educational programs are accredited nationally. There is a national certification exam, and the criteria for the education includes what we call the 3 Ps: physical and health assessment, physiology and pathophysiology, and pharmacology, as well as other coursework. We have over 50 years of evidence of the quality and safety of advanced practice nurses in the United States, and over 100,000 advanced practice nurses provide care. The advanced practice registered nurse role has been implemented in 70 countries. The World Health Organization recognizes the importance of advanced practice nurses, saying the advanced practice registered nurses help countries deliver high-quality, safe, affordable, patient-centered care around the world. There are some barriers to the advanced practice role. Certainly the inconsistency of regulatory requirements differ from state to state. There are institutional limitations on the role, and there is some confusion on the role. But nonetheless, the nurse practitioner or advanced practice nurse is able to have a significant impact on diabetes diagnosis and management. And as you'll see in the next segment, we have a video that shows how advanced practice nurses are providing care in the community during COVID.
We are here at the PAC Clinic, which is the Providing Access to Healthcare Clinic. And this clinic is a result of a UAB nursing partnership between the hospital and the UAB School of Nursing. We provide free care to patients who have diabetes. The patients have to meet certain criteria, and unfortunately, due to COVID-19, our team is not able to provide the care in the usual way in which we do. So as you know, the patients with diabetes who also have cardiac disease are at very high risks or poor outcomes related to COVID-19, because we know about 40 to 50% of patients with diabetes also have cardiac disease. So we have a very high risk patient population when it comes to COVID-19. So we want to make sure that we can meet as many of their needs as we can. Our staff continue to work very hard at home to orchestrate a delivery program now for our insulin. So they go through the deliveries that will be needed in our huddles. They communicate those needs to the nurse practitioners. The nurse practitioners come in on a day like today to make phone calls, but then we also package the insulin, label the insulin, and get the package, the delivery ready for our staff to take out. Then our staff takes those deliveries out on Wednesdays and Fridays of every week. So we continue to hopefully meet as many of the patient needs as we can, even though COVID-19 has certainly thrown some challenges our way.
Hello, my name is Bella Patel, and I'll be talking about basics of diabetes, focusing on the science of diabetes. At the conclusion of presentation, you will be able to determine physiological differences between type 1 and type 2 diabetes. You should be able to understand the balance between diet, activity, and medications. And you should also be able to know when it is appropriate to start insulin therapy. So starting with our first objective in science of diabetes, when we think of science, we typically think of pathophysiology behind diabetes. In this image, you can see that you have a healthy individual that is able to produce insulin, and the glucose is able to get into the cell to be able to use as energy. In type 1 diabetes, your pancreas has a failure to produce insulin, so your glucose is not able to get into the cell. In type 2 diabetes, your cells are failing to respond to insulin properly. So there's some kind of insulin resistance that is occurring. Let's talk a little bit about statistics. Why is diabetes so important and requires our attention? Diabetes affects 34.2 million children and adults in the United States. 26.9 million are diagnosed and the other 7.3 million are undiagnosed. Prediabetes affects approximately 34.5% of the population, and that is significant and requires our attention. Diabetes affects approximately 10.5% of the United States population, of which 4.2% of patients are in the age group of 18 to 44, 17.5% of the patients are in the ages of 45 to 64, and it impacts the geriatric population more so than any, at about 26.8% of the patients being over age 65. 12% are women and 14% are men. In this graph, you can see that there is not a lot of difference in between gender as a whole, but when you go into specifics of race and ethnicity for prevalence of diabetes, you'll notice that the highest prevalence of diabetes is in American Indian, Alaska Natives. You can also see that there are prevalence rates for Hispanics, Asian non-Hispanics, Blacks, non-Hispanics, and white non-Hispanics. This graph also elaborates on gender prevalence differences in each race and ethnicity group. The lowest prevalence that you can notice on this graph is in white non-Hispanic women and Asian women. Diabetes in United States, no matter where you are in the United States, there is about 43.5% to 68.4% of patients that still do not meet goals for glycemic control or blood pressure or cholesterol control. And this leads to more complications from diabetes. We know that uncontrolled diabetes can lead to acute as well as chronic complications, such as microvascular or macrovascular complications. And we want to avoid these as much as possible, or at least delay the progression or occurrence as possible. So the way we can do this is by tightening the control of diabetes, by working on getting the patient's blood glucose at target goal very quickly, and that will help prevent and delay the progression of comorbid conditions as well. So as a provider, we can help here by optimizing our own treatment and behaviors. We also want to optimize patients' self-management, their behaviors, and really help patients engage in their own care. We also want to change the places we provide care in depending on the patient's need. We can provide patients care in an outpatient setting, ambulatory settings, or an inpatient setting, or even in a telehealth setting. We also want to reduce our disparities by improving access to care and providing as many resources as possible. Looking at the prevalence among adults at a county level, you can see on this diagram that there are some dark blue areas that indicates that there is highest prevalence of diabetes in certain state or counties. And you'll notice that it is highly evident in the southern eastern part of the United States. And that is known as the diabetes belt, meaning that those dark blue areas have the highest or most prevalence in the United States. And you can see that Alabama sits right in the middle of that belt. A little statistics on Alabama. Approximately 12% of the residents have diabetes and another 5% have pre-diabetes. And when you look at these maps, you can notice that in 2016, the estimates of diagnosed diabetes prevalence varied across US counties, ranging from 1.5% to 33%. So diabetes is a complex disease with many causes, but it's characterized by high blood sugars. It is a disorder of metabolism and involves food and change of food into carbohydrates, then into glucose. And what happens is that that glucose enters the bloodstream. And that is where the role of insulin comes into play, where it helps the glucose come out of the bloodstream and then into the cells so we can use it for energy. So basically, diabetes impacts that part of the metabolism. So how is insulin produced and what is the role of insulin? We kind of talked about it, that whenever you have high blood sugars in the bloodstream, your pancreas is going to produce insulin so that it can enter the bloodstream, take that blood glucose out of the bloodstream into the cell so we can use it for energy. If for some reason there is some kind of defect in insulin, or if we just don't have enough insulin in the bloodstream to help glucose get out, then a person can have continuous high blood sugars. Other ways for blood glucose to get out of bloodstream is by filtering through kidneys and excreting through the urine. So if your patient is having blood sugar, continuous blood sugars, you may check their urinalysis and you may see that there is some glucose in the urine. So what happens when insulin and blood glucose don't work together very well? Well, that's when diabetes occurs. Diabetes is a group of disorders with high levels of blood sugars as a result of defective insulin The insulin defect may be related to insulin's action, its production, or a combination of both. So it's either not working very well if insulin is present, or there's just not enough insulin present to help the sugar come out of the bloodstream into the cell. As mentioned before, diabetes is characterized by high blood sugars, and there's different types of diabetes. You have type 1 diabetes. It's typically due to autoimmune destruction of beta cells and insulin deficiency. You can also have type 2 diabetes, which could be due to defects in insulin secretion, action, or resistance. There are also specific types of diabetes due to other causes, such as monogenic diabetes syndromes, in which one can have neonatal diabetes, maturity onset diabetes of the young, diseases of exocrine pancreas, such as cystic fibrosis and pancreatitis, and it could also be due to drug or chemical induced, such as with the use of glucocorticoid use, or if the patients are receiving treatment for HIV or AIDS, or if diabetes occurs after organ transplantation. Patients can also have gestational diabetes. This type of diabetes is typically diagnosed in second or third trimester of pregnancy. So there are multiple ways that one person can develop diabetes, but let's kind of focus on type 1 and type 2 diabetes. These are heterogeneous diseases, and we want to know the differences between them so that we can classify them. So it kind of helps us determine the therapy for them. In type 1 diabetes, you have the destruction of beta cells in the pancreas. They can also be destroyed by surgery, or it could be due to autoimmune causes, such as genetics or certain viruses. And it leads to absolute insulin deficiency. By the time the patients are diagnosed with type 1 diabetes, they have lost about 80 to 90% of beta cells at this point. Their body may be able to squirt out just a little bit of insulin, but it's very short-lived. They also have something called islet cell antibodies. Remember, if for some reason this was due to autoimmune reasons, the body is attacking itself, so we're going to produce some type of antibodies. In type 2, we're dealing with several metabolic disorders here. Insulin is not functioning properly. Pancreas has decreased ability to produce insulin, and the liver has inappropriate glucose production. So what's happening is your liver is producing lots of glucose, and your pancreas is not able to produce enough insulin. So that is going to lead to diabetes. There are also some environmental factors that can also influence the development of type 2 diabetes. And we also know that diet and lifestyle are important factors that has contributed to development of type 2 diabetes. There is also a hereditary component to both type 1 and type 2 diabetes, but more so in type 2 diabetes. So how can we diagnose a patient with diabetes? Well, every year, American Diabetes Association puts out the standards of medical care in diabetes, and it comes out every year in January in a supplement of Diabetes Care Journal. And this is the consensus state that comes from American Diabetes Association, as well as from American Association of Clinical Endocrinologists. So they come together, both of these organizations, they sit together and they decide on these standards of care based on the evidence, and they publish on this every year. So criteria for diagnosing diabetes has not changed in many years, and there's 4 ways that we can use to diagnose a patient with diabetes. I have this table posted here. We can either use a fasting blood glucose, which is greater than 126. So if a patient has a fasting blood glucose above 126, then we can diagnose the patient greater than or equal to 126. We can diagnose a patient with diabetes. We can even do a 2-hour oral glucose tolerance test in which we measure blood sugar after we give them a very sweet 75-gram glucose liquid or water. They drink that and wait for about 2 hours and we check their blood sugar. And if their blood sugar is above or equal to 200, we diagnose them with diabetes. We can also check something called hemoglobin A1C. And if it's greater than or equal to 6.5%, we diagnose them with diabetes. If patient is presenting with typical classic symptoms of hyperglycemia, we can do a random blood sugar check. We call it random plasma glucose. If for some reason they're presenting with polyuria, polydipsia, or polyphagia, where they have excessive hunger, excessive thirst, or they go to the bathroom too much, we can consider checking their blood sugar randomly. And if it's greater than or equal to 200, we can diagnose them with diabetes. Typically, it's recommended that we should confirm these tests with a repeat later, either with a repeat A1C or a fasting blood glucose to confirm diagnosis of diabetes. So pre-diabetes, which affects a very large portion of our population. And this is where we can help prevent progression of diabetes. So basically we have a window of opportunity to prevent development of diabetes. Pre-diabetes is the term that we use for individuals whose blood glucose levels do not meet the criteria for diabetes, but are too high to be considered normal. It is the immediate stage of impaired glucose tolerance and or impaired fasting glucose. And this is the time that we really want to focus on those lifestyle interventions, diet, activity, and even some kind of pharmacological intervention that we can use to help prevent or delay progression of diabetes. We want to consider screening individuals for prediabetes so that we can help prevent development into diabetes. Consider screening patients who are overweight, obese, with an A1C greater than 5.7%, anyone with high-risk race or ethnicity that we discussed earlier in this session, if anyone had any history of gestational diabetes, because if you have a history of gestational diabetes, you're at a higher risk to develop type 2 diabetes in later stages of your life. About 40% of gestational diabetes patients later go on to develop type 2 diabetes. If patients have any kind of cardiovascular diseases, then consider them for screening for prediabetes. If you notice that their blood pressure is high, if it is greater than or equal to 140/90, you might want to consider them for prediabetes. Anyone with HLD, cholesterol levels less than 35, or triglyceride levels greater than 250, consider them for screening as well. If patients are physically inactive or have a history of polycystic ovarian syndrome, or if they have any other conditions such as severe obesity, if the BMI is greater than or equal to 25, or if they're Asian Americans and if their BMI is greater than or equal to 23, consider them for screening for prediabetes. Sometimes you might find something during physical assessment that can kind of give you a warning sign, and you might want to assess them for prediabetes. When you are doing your physical assessment, and if you see something called acanthosis nigricans, that is darkening of the skin folds, and that's typically seen in the knuckles of the hands or around the neck. And typically seen in darker skin tones. In lighter skin tones, you'll see something called skin tags, and that's equivalent of the darkening of the skin folds. So if you find either of these in your patients during your physical assessment, consider them for screening for prediabetes. And that was our basics of diabetes and the science portion where we kind of talked about the pathophysiology, diagnosing portion, and how we can help prevent progression of prediabetes into diabetes. Thank you. Hey, I'm Bella Patel, and we discussed the science behind diabetes previously, focusing on the pathophysiology, classification, and diagnosing aspects of diabetes. And in this session, we're going to be discussing about art of management of diabetes. There are broad techniques that we can use to individualize care to meet our patients' needs. So I will be discussing various concepts on management of diabetes in this session. So the background of managing diabetes can slightly come from science, but majority of it is an art when you individualize the care plan. So remember that diabetes is a complex chronic disease with multiple contributing factors. Our clients can benefit from a holistic and an interprofessional team approach with patient being at the center. This is essentially the chronic care model. This model emphasizes on patient-centered team care and an ongoing collaborative communication and goal setting between all team members. Hence, the art of management comes into play with creating an individualized patient-centered care plan by having an interprofessional team approach. There are treatment similarities and there are some differences. So our entire goal, regardless of what patient we're dealing with, whether the patient is in the United States or somewhere in the world, we're wanting to avoid complications. So we want to avoid acute complications that would basically cause low or high blood sugars. So things like hypoglycemia, where patients may lose consciousness, or hyperglycemia, where patients' blood sugars are extremely high, where they go into states called diabetic ketoacidosis or DKA, or hyperglycemic hyperosmolar non-ketotic state or HHNS. So whether the patient is in DKA or HHNS, both of these patients have similar symptoms that they may present with, but there is just one symptom that may be different. So majority of times, these patients are going to present with really, really high blood sugars, or you may see that the patients are dehydrated. But patients who have DKA, they will have ketones present in their body, whereas patients who have HHNS, they are not going to have ketones present in their body. And that is a key major difference between these two states. We also want to avoid chronic complications such as microvascular complications, which occurs due to damage to the small or microvessels, or macrovascular damages, which involve the large vessels. And we want to avoid damage that can occur to the eyes, kidneys, legs, or their heart. With diabetes, there is an increased risk of blindness, stroke, heart attack, kidney diseases, peripheral vascular disease, and they also have increased risk of infection. We also want to try to avoid these acute as well as chronic complications. And the key players that can help us to avoid these complications are diabetes self-management, education, and support. With these two key players, we can avoid these complications, and these patients are in continuous need of these two, either diabetes self-education and support. So proper management of diabetes depends on the input, what the patient is able to tell us and give us input in. And technically let us know what is really going on with them. And also what a provider can input. So when it comes down to provider's input, before I step into a patient's exam room, I usually look at their lab values, their blood sugar log. Look at the patient on a paper or a EMR, kind of get a whole picture. What was going on with the patient before? And also come up with a way, some kind of mechanism that I want to target for this patient and their diabetes. So that's on a provider's input. But when it comes down to patient's input, which is a pretty important part in management of diabetes, we want to kind of dig a little bit into what patient can tell us. Is a patient able to let us know how many times does he check blood sugars? Patient, you want to dig a little bit into their work schedule. When do they work and how do they work? Do they work during the day? Do they work during the night? What time do they wake up? How often do they eat? Also assess on what is their biggest meal of the day. It kind of helps us come up with the therapy for them. You also want to ask them if they check their blood sugars often. So I'm basically gathering information to make an informed decision so that we can help guide their care and develop an individualized plan with them. We also want to include lifestyle changes, and we really want to emphasize on diet modification and increasing their activity as tolerated and depending on what they are willing to do. Normally, I take baby steps in regards to diet and exercise until the patient can get to the target that we really want them to be at. So successful control is what we all are trying to get to. Patients want that. I want that as a provider. We all want that. So how do we really measure control? And that's typically via A1C, hemoglobin A1C. And that is an average, a 90 to 120 day average of blood glucose levels. So when you look at averages, you can imagine that averages can be misleading. For example, patients can have blood sugar readings that run from 100 to 130, and you're going to end up with an estimated blood glucose average of 115. So we're thinking that's a pretty good control. But when you have blood sugar readings that start from 60s all the way to 140s, and you still end up with a blood glucose estimated average of 115, both of those blood sugar readings are very different. So averages can be misleading. So that's why it's important that when we are looking at control of the blood sugar, we're looking at the A1C, but we're also looking at the estimated average blood sugar readings. So when I have a patient who comes into the clinic and they're presenting with their blood sugar logs, I'm looking at their blood sugar readings and comparing it to their A1C to make sure that they are correlating with each other. And if they're correlating with each other, that's perfect. We can say that the patient has a good control, or if the patient does not have a good control. But if for some reason their estimated average blood sugar readings are not correlating with your A1C, then we need to dig a little bit more. Why is there an inconsistency between these two? So you would want to talk to your patient, kind of ask them what was going on with them. And you want to dig a little bit more into why that is occurring. American Diabetes Association indicates that if an A1C is less than 7%, it can be classified as a successful control. American Association of Clinical Endocrinologists like their patients to be at less than 6.5%. So for me, when I'm practicing in my clinical practice, I typically look at their A1C, and if it's in between 6.5 to 7%, I'm pretty happy with their A1C levels and their blood sugars. I would consider them that they're pretty well controlled. Apart from just A1C, we can also look at something called preprandial capillary plasma glucose to assess for control. Preprandial basically means before the meal. So checking the blood sugar via a finger stick can let us know what their blood sugar reading is before meals. And if it falls in between 80 to 130, we can consider it to be pretty well controlled. And the second portion of checking blood sugars, we have finger stick, would be peak postprandial capillary plasma glucose. So checking blood sugars after eating. Postprandial means after eating, and typically after 2 hours of eating. So when patients check their blood sugars after 2 hours of eating and their blood sugar is less than 180, then it's considered control. So we discussed treatment similarities. Let's discuss some differences. We talked about successful control, which is anywhere between 6.5 to 7% A1C. Shifting towards an unsuccessful control, that is anything above 7%. And this is important because the better we control and the faster we can get to it, we can avoid those acute and chronic complications and even comorbid conditions that can occur due to diabetes, uncontrolled diabetes. And you want to remember that typically we assess glycemic control at least 2 times a year in patients who are meeting treatment goals, and at least quarterly in patients who are not meeting treatment goals, as well as in patients who we have made as providers some changes in their therapy. Oh, sorry about that. All right, so how do we achieve that control? Again, it is the art of balancing between diet, activity, and medications. And using those things and what is the patient willing to do to shape the care and their self-management. With diet, there's typically 2 options that I address with the patient. When a patient is newly diagnosed with diabetes, they're typically referred to a dietitian and they go into a comprehensive diet education with the patient and also recommend specific carbohydrate servings per meal and a snack to a patient. And patients are recommended to follow that regimen. So as a provider, when a patient comes to the clinic, what I typically ask them is, how many carbohydrate servings have been recommended to you? And they would be able to tell me, and this is where I go into analyzing and assessing if patient is able to follow simple methods or a sophisticated carbohydrate counting method. So with carbohydrate counting, this would require patients to read labels. We would also need to assess how good a patient is in math. With carb counting, it requires patients to learn how much quantity-wise and how much can they consume certain foods and how much of the quantity contributes to a serving of carbohydrates. Now, 1 carbohydrate servings equals to 15 grams of carbohydrates. So if a patient typically tells me that I have a peanut butter cracker package, so about 4 peanut butters for a snack, I would ask the patient how many servings that is. So patients should be able to tell me that I read the label and there's about 30 grams of carbohydrate in those 4 peanut butter crackers in that packet, and that's 2 servings of carbohydrates. If the patient is able to do all of that, then I feel confident to be able to provide them this sophisticated carbohydrate counting regimen, as well as provide them some type of insulin therapy that involves carb to insulin ratio. So there's a way we can use carbohydrates to prescribe insulin therapy as well. There's a simpler method that we can provide to the patient when it comes to diet. If the carbohydrate counting is becoming too complicated for them and you feel that patient may not follow that regimen, then we can ask the patients to follow a simple plate method. And what that plate method involves is that you ask them to grab an 8-inch diameter plate and devote half of that plate to vegetables, such as spinach, cucumbers, okra, lettuce, or tomatoes. A quarter of the plate would be to protein and the other quarter of the plate would be to carbohydrates. So typically patients would have 3 to 5 servings of carbohydrate recommended per meal. Since they're following the simple plate method, that quarter of the plate does count as a carbohydrate serving, and they can have up to 2 to 3 other carbohydrate servings outside of the plate. And that could be anything from milk or some kind of fruit, bread, or grain. So the plate method is a bit easier, and there are visuals out there that we can provide to the patients, such as placemats that can have the visual on them. So it kind of helps patients guide on how much goes on what part of the plate. So apart from diet, activity is also very important for diabetes regimen and management of diabetes. You want to tailor to their age and their condition, and that's the art. So recommendations for patients with diabetes is to conduct 150 minutes per week of moderate intensity physical activity, such as brisk walking. And typically we recommend for them to walk at least 30 minutes per day, 5 times a week. If you have someone with heart failure, it might be a challenge for them to walk 30 minutes, 5 times a week. That's a little bit too much. So it's important to tailor to their ability. We may want to talk to the patient and see what they can do. If they mention that I walk to the mailbox and I come back and I'm short of breath, then we might want to encourage them to just walk till there and come back, and maybe slowly increasing their activity throughout the day. If you have elderly patients and they're at risk for falls, we might want to encourage them to do chair aerobics or use stationary bikes so that we can prevent any falls. It's also important to avoid acute complications while they're exercising. So if they're going to be exercising for a sustained amount of time, and it could be a pretty intense activity, it might be a good idea to let your patients know to check their blood sugars prior to the activity, because we want to prevent a complication such as hypoglycemia. If patient's blood sugar is less than 100 prior to an activity, then we might want to encourage them to eat a snack with a fat, protein, and a carbohydrate. The reason why we want fat and protein in a snack is because carbohydrates can be digested pretty quickly, and fat and protein takes a little time to be digested. So when you have a combination of all 3 of these in a snack, it helps those carbohydrates to linger on a little bit, so that it's beneficial to these patients with diabetes when they're exercising, so they would not have any hypoglycemia episodes. Apart from diet and activity, medications are also important in managing diabetes. And there's algorithms out there that we can use or just review on yearly basis. American Diabetes Association standards of care have tables and graphs that we can easily print and keep it with us in our lab codes and follow that regimen. So a little bit about that algorithm. Typically, type 1 diabetes are going to need insulin therapy. That's their gold standard. Remember, they don't produce any kind of insulin, so they will be on some form of insulin. They may be on multiple daily injections, or they may have a pump. With type 2 diabetes, the gold standard of therapy is metformin. So any patients whose A1C is less than 9%, we typically start off with metformin plus lifestyle modification. That includes activity, physical activity, and diet. So with physical activity and diet modification plus metformin, that would be the initial treatment stage. You would wait 3 months and see how the patient's doing, recheck A1C. And if the patient is not at the goal, you would consider adding a second agent. And when it comes down to adding a second agent, we're kind of assessing for something called atherosclerotic cardiovascular diseases. And you're assessing to see if the patient has that or not. And depending on if the patient has it, we would choose that agent, because there are certain drugs out there that have the cardiovascular disease benefits associated with it. So drugs such as Jardiance or Victoza, SGLT2 inhibitors, or GLP-1 receptor agonists, they both have proven CVD, cardiovascular diseases benefits associated with them. And that kind of helps us determine which medications we're going to add. And then we'll do a repeat A1C in another 3 months. And if they are still not at the goal, we're going to add a third agent. Again, after 3 months, if they're still not at the goal, we will consider starting them on insulin therapy. If your patient has an A1C at any point greater than 10%, you want to consider dual therapy. But if they are markedly symptomatic, you want to start insulin right away. So again, importance of individualization is the key here, and it is crucial to success. Clients who have a shortened life expectancy, whether it be a terminal disease or maybe have cancer, or if they're on hospice, then you may need to lessen the stringency of A1C control. Those who have poor resources or poor support system, you may think that I'm okay if their blood sugar is a little bit above 7% and they're running at about 8%. Again, the goal here is that we want to avoid the acute complications or hoping to reduce the risk of chronic complications. But acute ones are what we need to pay attention to, a little bit more attention to. So as long as we're avoiding the hypoglycemia or the hyperglycemic states that we talked about, the DKA or HHNS, we're okay. If we are a little bit less stringency on A1C control. So for those who have shortened life expectancy, we want to avoid acute complications. And they may not even live long enough to experience the chronic complications that they may have to face due to diabetes. So as you look to prescribe insulin, which is an art, things you should consider are, have they ever been on insulin before? Are they naive to insulin? Patients may require more education on insulin or on how to give themselves insulin. The insulin injection techniques, making sure that they are rotating sites. They also need to know what insulin to be taking it when. So there are many aspects of insulin therapy in the initial stage that we may need to cover to clients who are new to insulin compared to the clients who have previously been on insulin therapy. So other things to consider if you're not starting new insulin is, are you planning to titrate the insulin? If they're not at the goal, why are they not at the goal? I normally get the patients to tell me a little bit more about what's going on with their therapy. If they're not at the goal, I kind of go into history taking and details. Tell me a little bit about, are you compliant with insulin therapy? Because they might not be compliant with insulin therapy, and I might keep on going up, titrating the insulin up. And whenever they do decide to take insulin, they're going to have a drop and they're going to cause an acute complication such as hypoglycemia. So we want to avoid that. So we want to talk to the patient. And I typically approach this as, I want to be able to help you, and I'm not here to judge you. I just want you to be honest with me. Can you tell me if you have skipped any insulin dosages in the past week? And typically after telling them the scenario that if I keep on going up on the insulin, their blood sugar might drop, and I don't want that for them. So when we have a discussion like that, typically patients will end up telling you that I might have skipped 1 or 2 insulin dosages. So that is where the therapeutic relationship, patient and the provider relationship comes into play. Also, other things that you want to consider is the patient resistant to insulin? Typically, patients who are obese, or if they're taking steroids, or if they have some type of infection, they may be resistant to insulin. There may be some patients that are sensitive to insulin. So if they're elderly, thin, or if they have some kind of renal impairment, they may be sensitive to insulin. Some other things to consider when you are switching insulin are the categories of insulin. So there may be a situation when you might have to change insulin. It may be because the insurance does not provide coverage for a specific insulin, or the patient does not have enough money to buy a specific type of insulin. So there may be many situations where you might have to switch insulin. And when you do, you have to consider the category of insulin. Are we trying to switch between rapid and fast, or short, intermediate, or long-acting? Thinking about what different categories of insulin, what drugs fall within those categories, and switching between them. Try to assess if the dosages are equivalent is the art of managing insulin therapy. There may be special needs with older adults because they're more sensitive to insulin. You also want to screen for geriatric syndromes such as polypharmacy, cognitive impairment, depression, urinary incontinence, falls, persistent pain. All of that could happen with older adults, and which can affect diabetes self-management and diminish quality of life. You also want to look into patients with renal failure because they are more sensitive to insulin therapy. Also for patients who are visually impaired, if they are on any insulin injections, they may do better with pens because you can hear the clicks and count the dosages. So preference would be to place them on insulin pens, educate them properly. So those are some of the things that you have to think about. And that's the kind of art to bring it all together to help manage the patients better. Thank you.